Hi, everyone. In this video, I'll be going over treatment planning and progress notes, and this video will be split into treatment planning, and then in the second half, we'll do progress notes. So let's start with a treatment plan. So treatment plans take the information that you've gathered thus far in the assessment process and turn them into a plan for therapy, where you will address the presenting problem and attempt to help the client meet the goals that you come up with. Within the treatment plan, you're specifying the specific clinical goals for treatment. These include the client's long-term goals, as well as the therapeutic goals, which involve making changes that will be necessary to achieve the long-term goals. Your selection of goals should be informed by your therapeutic orientation and/or the evidence-based programs that you'll be using in therapy. Treatment plans should always be collaborative. The goals should be developed with the client and agreed upon by all involved in the treatment plan. If the client doesn't agree with the goal or doesn't think that it will help them achieve their long-term goal, they're going to be less motivated to work toward achieving it. So making the goals collaborative aligns with the best interest of the client and aligns with our ethical codes of autonomy and self-determination. Purpose of a treatment plan. There's lots of purposes fulfilled through the creation and use of a treatment plan. Perhaps the most obvious purpose is that the goals and interventions in the treatment plan identify the specific steps needed to reach the long-term goal. For example, if someone came to therapy because they felt anxious all the time, a goal of increased use of relaxation techniques indicates one step that will be taken to address anxiety is relaxation. The associated interventions, such as practice mindfulness, learn deep breathing, use progressive muscle relaxation, and so on, provide clear steps toward how the client is going to reach the increased relaxation goal, which is going to reduce the anxiety. Note that the goals and steps may be different for different people, even if they came in for the same thing. That's okay. Treatment plans also make sure that the work that you're doing in therapy is goal-directed and purposeful. You're both working toward the same thing and have the same expectation of what will come from therapy. You're not just sitting there talking about the weather. Using a specific and measurable goal also allows you to track progress. Without a clear starting point, such as a number of clearly described panic attacks, how will you track the progress of reducing panic attacks? So it's helpful to have a goal that indicates where you're starting, like 7 panic attacks a day that look like XYZ, and where you're trying to go to maybe 4 panic attacks a day. Having a clear treatment plan with goals and interventions also helps ensure that you're meeting billing requirements. Insurance companies and the Department of Mental Health want to know what you're working on and how you're doing it. Further, auditors want to be able to see that your assessment plan is consistent with the identified functional impairments in your assessment. I'm sorry, I said that backwards. Auditors want to see that your treatment plan is consistent with the identified functional impairments in your assessment. So if you've identified impairment in social areas, then you're going to want to address those in your treatment plan with a goal or with interventions. The interventions that you provide also help team members to know what to work on with the client. This is especially helpful for programs that include multiple team members like Wraparound. By providing a clear goal, then all of the different people working with the client are all working toward the same thing and can help to support the client in reaching their goal. Finally, a treatment plan is going to support and encourage participation. First off, because you're creating goals that the client agrees to. And second, the section of the treatment plan where you describe the client's role delineates exactly what the client is expected to do in order to help make therapy effective for them. Okay, so what is this treatment plan? I provided you here with a screenshot of the client treatment plan that's used at DMH contracted sites. And this is what you'll be expected to use when you create your mock client treatment plan. And I'm going to walk you through each of these sections here. The first part of the treatment plan is the long-term goal. And this is the client's long-term goal for their life and should be written in direct quotes from the client. Because this is a direct quote from the client, it does not need to be written in SMART format. I'll tell you more about SMART format next. And it does not necessarily have to be a therapy goal. So the example that I've provided here, sorry, on the top, is the client said to be happy and to feel loved. And that's what would be written in the box that you see here. This is a quote specifically from the client of what they have as their long-term goal. and you're not going to modify it in any way. You're just going to write it in there in the client's long-term goal. Next are the client's short-term goals. These are the therapy goals and must be connected to the impairments you cited in your assessment and to your diagnosis. For example, if you talked about someone who's significantly impaired by their PTSD symptoms in your assessment, your goals should be addressing one or more of these symptoms directly. If you have a goal about oppositional behavior, this does not align with your assessment and is going to be problematic. Okay? So the goals that you write must be therapy goals, unlike the long-term goal, meaning that they have to be things that you, the therapist, and perhaps others in the treatment team can help the client with. A goal of saving money, while a great goal, is not something that you're going to be able to help the client with in therapy because you're not a financial planner and this is outside of your scope of practice. However, you could make a goal about reducing impulsive behaviors and include something like wasteful spending as an example of those impulsive behaviors that you're trying to reduce. This might be appropriate for someone who struggles with not thinking about their decisions. Okay? And that becomes a therapy goal. Short-term goals must be written in SMART format if you are working at a DMH contracted site and at many other community-based sites as well. I personally recommend you always write your goals in SMART format, regardless of who it is that you're billing. But some therapeutic orientations don't lend themselves to this type of goal writing in therapy, and that's okay. So a SMART goal is specific, measurable, agreed upon, realistic, and time-based. With specific, we mean that it's clear and well-defined. If you're talking about panic attacks, what do they look like for this person? Your panic attack is probably different from my panic attack. So explain what it is for this particular client. Do their panic attacks include heart racing, sweating, passing out? Whatever it is, include it in the parentheses to make it specific. Measurable or quantifiable, this means that the goal should measure when and how the objective is tracked and achieved. So this gives us a starting point and an ending point. How many panic attacks and how long do they last? So here I have from 7 times a week, meaning that the panic attacks are happening 7 times a week, and I'm trying to get them to 4 times a week, okay? This goal could even be strengthened by adding how long the panic attack is, and I could put that either in the parentheses or in the next to the time, from 7 times a week for 30 minutes per panic attack, for example. Okay. Next is agreed upon, and this basically just means that the client should agree to the goal. It should be collaborative. This isn't indicated anywhere in the goal itself, but would be indicated in the progress note that you write for the treatment planning session, which I'll get to in the next video. The SMART objective should also be realistic. It should be reasonable for the client to achieve. Reducing panic attacks from 10 times a day to 1 time a day is not realistic, and you're setting the client up to fail. So make it realistic. In this case, I've gone 7 to 4, which seems realistic to me. But again, you would want to make sure that it is something your client agrees to. Do they think they can get the panic attacks to 4? If not, change it to what they agree to. Maybe it's 6. Okay. Finally, time-based. There should be an end point or a reevaluation point so that you can track progress and reassess goals as necessary. At DMH contracted sites, this duration is usually 3 months. And so you can see that I have in the next 12 weeks in my goal. And this helps us to make sure that we are tracking progress regularly and making adjustments if we need to. Okay, so the goal that you develop is then written in the short-term goal section, as you can see here on this page. You only write 1 goal per box. So assuming that you have another goal, and 2 to 3 is standard, you would then write the second goal in short-term goal 2 box, which is on the second half of the page. So don't write 2 goals under objective 1. You would write your second goal under objective 2, which is later on. Here are some examples of SMART goals, and you can see that they each feature everything in the SMART acronym. So increasing use of calming statements, made specific by quoting those statements, I'm calm, I'm in control, etc. From 0 times a day to 1 time per day. So we're measuring that and we're making it realistic. Going from 0 to 1 is realistic. And the time period is the quarterly assessment period. Next one, increase socialization by participating in community-based activities. being specific about what those are, youth group, library events, etc. 2 times a month from 0 times a month. So where did we start? Where are we going? To make it measurable and realistic. And over the span of 6 months makes it time-based. And then the last one, decrease anxiety in social situations. And what does that anxiety look like? Feeling judged, worrying about what people think, isolating, etc. From a level 8 anxiety to a level 4 anxiety. So we're making this measurable by ranking what the client has reported as severity and making it realistic by cutting it in half, which the client may have agreed to, that is realistic for them, and making it time-based by saying over the span of 3 months. These would all be great SMART goals to use. Some not so great goals, some problematic goals are listed here, and I'll tell you kind of what the issue is. So the first one, will consistently meet with psychiatrists and comply with medications. This isn't a good goal for lots of reasons. First off, you're not a psychiatrist, and this goal doesn't specify anything you, the MFT, is going to do in therapy to help the client. Okay? So this potentially is going outside of your scope of practice, which is illegal, and then doesn't give you anything to do in therapy. So what happens when they go to the psychiatrist? You say, good job? What do you do? Okay? You could change this to something else, like we'll utilize positive self-talk to increase follow-through. That may be a bit of a more helpful goal and something you could work on therapeutically by working with them on positive self-talk and on follow-through and on barriers to follow-through and so on. And that might be better. And of course, none of these goals have any measurement to them or any time-based component, so that's problematic. The next one, client will request linkage. Okay, and after they make that request, what happens? Right? What did you do as a therapist? What are you going to do? Not very helpful. And how is this supposed to address the client's presenting problem? That's not clear, okay? And then the next one, client will reduce symptoms or client will reduce severity of symptoms. Which symptoms? Which ones? Reduce from what to what? How will we know the client's been successful? Not good, don't do. The next section is the clinician's role. And in this section of the treatment plan, you're indicating what you, the therapist, will be doing to help the client work toward the short-term goal that you've identified. Remember, ours is about panic attacks in this example. You'll have a separate clinician's role for each of your short-term goals. Okay, so the interventions you write in this box here should match with the goal in objective 1, and then you'd have separate ones for objective 2, and so on. For the majority of cases, you're checking off MHS as the type of service, as you can see there, which stands for mental health services. You would use TCM when you're creating a targeted case management goal, and you would not check off med support because this is for a psychiatrist or an ARMT, which you are not. It's strongly recommended and required in this class that you provide 3 separate interventions that are clearly linked to the goal for each goal. So in the clinician's role section of your treatment plan that you create, you must include 3 things that you are going to do to help the client meet their goal. Okay. Common words to use here are process, explore, teach, and so on. If you're required to use a specific evidence-based program, such as managing and adapting practice, you will need to use that EVP language in this section, but your agency will teach you about that, and you'll get training on what those interventions might look like. So for our panic attack goal, 3 interventions are listed here. Therapists will provide psychoeducation regarding the cognition behavior affect link as it relates to clients' panic attacks. Therapists will explore panic and anxiety triggers with clients, and therapists will model anxiety reducing techniques, including deep breathing, mindfulness meditation, progressive muscle relaxation, among others. You would not write something like, therapists will provide therapy. No, that's obvious and not helpful. So some well-written interventions are here that discuss what the therapist will do during the therapy sessions and how they will help the client meet the goals. Note that you can't just copy-paste these interventions here into your treatment plan. You need to make sure that they're relevant given your client's functional impairment, their goals, their strengths, and so on. Remember in your assessment that you gathered information about their strengths and about what has helped them before in therapy. So if you can incorporate some of those into your interventions, that's really showing consistency between your assessment and your treatment planning. Obviously, these are poorly written interventions. They're not clear, they're not detailed enough, they're dealing with things outside of the scope, outside of your scope of practice, and they're involving things that you, the therapist, are not doing. So these are Not good. Okay, the next section in the treatment plan is the client's role. And as you may have guessed, this is what the client is agreeing to do to help them meet their goals. And just like with the therapist's role, it's strongly recommended and required for this class that you have a minimum of 3 things that the client will do for each goal. Okay? It's helpful, again, when these are consistent with the things that you plan to be doing, and the things that you've written in the clinician's role. For example, you can see below that number 1 is about using a thought journal to observe and monitor triggers for panic. You may recall in the clinician's role section, I said I would help the client explore triggers. So this shows consistency. So I'm going to be helping the client explore triggers, and they're going to use a thought journal to observe and monitor their triggers. So it's consistent. The other things that I've written, client will practice using anxiety reducing techniques. Remember, in the clinician's role, I said I would be teaching the client anxiety reducing techniques. And then client will monitor frequency and severity of panic attacks. Makes great sense, okay? The things that you write here cannot include client will come to therapy or client will participate in therapy. This is a given. The client's gonna come to therapy and participate in therapy. Even though this may be problematic for the client and they may have resistance, that's not something you would write in client involvement. That's not involvement, okay? Don't do that. Here are some other examples of things clients can do. Practice social assertiveness, relaxation, problem skills, etc. with therapists. You wouldn't write all of these in one, you would split them out. Okay. Client will practice skills at home, report back to therapist about difficulties, etc. Research jobs, look into different social activities, and so on. Of course, remember that these are things the client actually agrees to do. Okay, next, the last section of the treatment plan is the support member's role, and this should be completed for minors when you have a parent or a guardian who's involved in the therapy process. You would begin with checking off whether or not the family is biological. If they are, check biological. If not, select other and specify below. Then you would check off whether the family is available, whether the client consents to their participation, and whether the family agrees to participate. Assuming that these are all marked yes, you would then elaborate below by explaining what the family or support person agrees to do to help the client meet their goals. Just like with the therapist and the client's goals, 3 is the magic number here, and you should have 3 things listed for each of your goals. Some examples are written here. So parent will provide reminders for client to complete thought journal and monitor panic attacks. This is consistent with what I wrote in the client's role. Remember, the client is going to do a thought journal and they're going to monitor panic attacks. So having the parent provide reminders is helpful and is consistent with that. Parent will positively reinforce client's use of anxiety reducing strategies. Again, the client said they were going to practice it. I said I was going to teach it. So this is creating consistency again. And parent will encourage client's use of anxiety reducing strategies by practicing them with her is also great and is consistent with what we've got so far. You would not write, parent will bring client to therapy. I know that that's helpful and that's important and necessary for the client to come to therapy, but that's just not what we write in a treatment plan. You need to dig a little deeper there, okay? Okay, remember that all of these sections, so the clinician's role, the client's role, and the support member's goal should be completed for every single short-term goal that you write. This isn't something that you just complete once and then you have separate goals. You need to complete it for every short-term goal that you have, okay? All right, so that's it for treatment planning. And in the next video, I will go over progress notes. So let me know if you need clarification on anything or if you have any questions. Thank you for listening.